that look like a clean incision? It looks like it was done pretty quick, right? Just kind of split open and you literally put your hand in there and kind of start spreading things around, right, with sterile gloves on and trying to release those posterior compartments, right? So that can obviously have more implications down the road. They can have some kind of neurological deficits because, again, that's not done in a slow, controlled manner in the operating room. Make sense? Yes, sir.
Is there a specific, I imagine there's a specific area you're trying to hit too? Like
There is. There are surgical techniques and approaches. I won't get into those because, again, I took those out of the lectures because I don't think you guys need to know that necessarily. If you deploy, like when I first came on active duty, I deployed, right? Attached to the Marine Corps downrange at a FOB, and we were doing these, right? So they were like, hey, let me show you how to do them real quick. That was it. That was my training. Okay? They were like, here's your landmarks in general, right? Try to be quick and efficient, and when you're done, when you make the incision, then you start spreading, spread, release, 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 suction, 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 and then we pack it down with sterile gauze, and they get medevaced to the next echelon of care. Okay, so it was kind of down and dirty, right? So to answer your question, I guess, if you find yourself doing these in a deployed environment, some of you guys that are special operators, special forces, etc., have training in this, and that's good, I think, because again, time is tissue, right? If someone's downrange and you don't want to wait, right? This is something that if you decide that they have acute compartment syndrome, you need to do something about it. Okay, makes sense? So is this a surgical emergency? It is. And that's the reason, again, I wanted to kind of circle back to this and just have you guys understand that when the difference between acute compartment syndrome and chronic exertional compartment syndrome is really in the history and in the presentation, right? And sometimes in the setting, like we just discussed, right? If you're downrange, kinetic environment, ongoing operations, people are getting blown up, people are getting crushed, right? You're going to see this type of stuff. Make sure you have the appropriate level of training. If you're in a hardened facility here in the States, CONUS, you're gonna call someone like me, right? And say, hey, this patient presented, and I think he's got acute compartment syndrome. So that's usually again going to be more like a, urgent care ER type setting, hopefully, right? Because if you're calling me from clinic, I'm automatically assuming it's chronic exertional compartment syndrome, right? I'm just going to assume that because the patient walked in and said they're having these symptoms, but they're not having the symptoms at the time, okay? Unless they walked in quickly, right? They ran in or something like that, right? But they've been sitting there for 30 minutes and the symptoms resolved, correct? Okay. So it's important to kind of distinguish that, okay? So yesterday you saw there was still like some areas where that slide was like the text was kind of weird. That's me hacking things, removing numbers, okay, because there was a lot of numbers on this slide before. And I told you guys before, I think it's important for you to know normal, right? What's normal? 15, right? Because that's pertinent, right? Because if you find yourself, again, in a situation where one of these, usually this needle's on a wall in a box, right? It's in a box. It's like a kit box, basically. It should have not only the digital device, but also the side-ported needle and syringe and all the supplies you need to do the testing, right? But if you find yourself in a situation where you are questioning it and you're like, okay, I got to do a quick striker needle, Ortho's on their way, general surgery does this as well, obviously, right? You can do a quick pressure measurement. By the time the specialist rolls in, you're like, hey, I did a reading, it was 30 millimeters of mercury. I know that's not normal, and it just kind of states the case, right? Make sense? So I think that's important. But knowing all these deltas, figuring out the differences between the blood pressure and the readings that you're getting on this device, I don't think there's any value there because, again, that requires a certain level of training that you can certainly explore. I'm just talking to OC Arnold about that. It's something you can explore in the future, but it's not testable, I think, at the entry level. Okay? Is that good? We're good with that? I can just add those numbers back if you guys want. Nobody left? All right, so I wanted to circle back to this, right? Because next week more so, right, we're going to start talking about nerve distributions, right? Because we're really going to get into spine, okay? So I think it's important for you guys to understand that when we're talking about paresthesias, right, that's that numbness and tingling in the anterior leg, we're talking about the first dorsal web space, right? So the space between the great toe and the second toe, right? Does that make sense? So that is the deep peroneal nerve. Okay? You guys remember that? That's what the deep peroneal nerve is. Okay, that's where you test for it. So that's what we're talking about there as far as compartments. That's the nerve that's involved there. Okay? The weak ankle dorsiflexion, right? Possibly foot drop. That is what? I added the word, what's in parentheses there? Active. Don't get that confused. That's the patient can't do it. Okay? They can't actively do it because, again, there's compression. Okay? Now, the passive flexion there of the great toe, that's the muscle group that we were referencing in the anterior compartment. That's the extensor hallucis longus. Okay? So again, I told you yesterday, when someone calls me, I tell them, go ahead and tape the scalpel, have a bottle of betadine, have a cleans, whatever. And what you're sounding like is like this patient has something serious going on. I'm going to walk in, patient's laying on a gurney, and I grab that toe, I'm going to keep walking, right? As I keep walking, it's flexing, right? Because I'm walking my way around the patient's bed to look at the other side as well. If they go, ooh, that doesn't feel good, okay, we're good, okay? Or they do nothing. But if they jump, right, then that's pain out of proportion. That's what we're talking about when we're talking about acute compartment syndrome. That compartment is so compressed, right? The vessels, the muscle groups, the nerves in that compartment are so compressed that it's causing them to have that pain out of proportion. Does that make sense? So that is something you're doing passively, okay? Passively, right? So don't get those two confused. And then passive foot plantar flexion, okay? This throws people off because, again, it assumes a certain level of knowledge, but I would tell you that it says foot there, right? It doesn't say ankle. You guys very commonly are taught ankle plantar flexion, and that is a thing, obviously, you know that. But there's also foot plantar flexion. So plantar flexing the foot versus plantar flexing the ankle puts certain muscle groups on stretch versus others, okay? That's the only concept I want you guys to understand about that. Because as we get into lower extremity a little bit later on, I'll go through that a little bit more, okay? But just understand that for the purposes of acute compartment syndrome, putting the stretch on the extensor hallucis longus by flexing the great toe and having a significant response by the patient means that you should be concerned and ready to act. Okay? Are we good with that? Yeah, that's the pace I wanted to explain that. Any questions about that concept? Okay, now at the bottom there, you've been provided with the lateral compartment, the deep posterior and the superficial posterior. I do recommend you take some time and look at those. But again, I told you guys many times, gold, gold is something I consider important to know. Okay. You good with that? Okay. All right. So, and again, anything that's acute compartment syndrome is an acute surgical concern, meaning it's surgery until otherwise proven, and you need to refer immediately. What does that mean? You pick up the phone, right, or you run across and find somebody. You're at a shock trauma platoon, right, or you're out there downrange, you go find the surgeon. Get him out of bed. He's usually curled up reading some weird, some weird novel or something. Get him out of bed, tell him you got something going on. Okay? Makes sense? Now, if it's chronic exertional compartment syndrome, what are we going to do?
Wait 30 minutes.
Treat it not off, but how do we do that?
Wait 13 minutes.
Modify activity for now, right? Because guess what? If they're having pain 1 mile into a run, and they run 2 to 3 miles a day, right? Say they're infantry or something like that, they're running for unit PT. Are you helping their cause or hurting their cause, right? So make sure you modify their activity at first. Remember we talked about those modifiable for chronic, right? Up here it says gait retraining. That gait retraining could literally be if they're heel strikers when they run, right? Or if they have weird posture, weird gait, some things you can correct, right? And maybe their symptoms improve, okay? Then that's the way to go. But having said that, maybe they need permanent activity modifications, right? So, and I'll throw my service under the bus, right? So if you're Air Force and you're not, you can be on a permanent profile. You just can't be, okay? So if you can modify certain activities, I've put a lot of airmen on permanent no-run profiles, that's a thing. You're talking about Marines, that was my patient population for 10 years, right? They gotta run. There's no such thing as a permanent profile. So as soon as you start talking to those patients, and depending on what service they're in, their MOS, AFSC, et cetera, you gotta take that into account and tell them, hey, this could be career changing. Okay, and make sure we wanna go down that road. Why do I say that? Because I wanna be very clear. So I talk about this testing, right? When people would come to me to get this testing done, I would do my best again to explain to them, maybe put a little bit of scare into them just so they completely comprehend what is about to occur, and tell them, are you ready for surgery? And they say, well, if I don't need surgery, I don't want it. Well, yeah, but that's what this testing is for. This testing, you have done all that stuff already. You've done all the gait retraining, activity modification, modify your shoe wear, et cetera. You're talking to a surgical person. So I'm doing this test to figure out if I think you need surgery, right? And if the patient tells me, I don't want surgery, then I say that I'm not doing the test. And then I had one person, she was crying, right? She was like, well, I was told that if I don't get this test, I can't get the diagnosis. And I said, that is incorrect, right? This is not diagnostic in nature. This is in the sense that it's not going to tell you 100% that even having surgery is going to make you better. Does that make sense? So if you don't want surgery, you shouldn't pursue this avenue, right? Because it's not pleasant, correct? Okay. So if you guys are using the S word in your practice, be careful with that. Okay. Surgery, right? The S word, not the other word, right? So be careful with that. Right? Let us talk to them about the surgical indications, but make sure that they understand that they're coming to get testing, if you're referring to someone like me, to figure out if they need further management, because now non-operative management has failed. Does that make sense? So if because we review our referrals, right? Someone refers someone to me for this testing, I look back and see, have they had any physical therapy? Have they had any gait retraining? Have they had any activity modification? If the answer is no, I will respond to the console and say, hey, let's try some non-operative stuff first. Right? Because when they come to me, am I going to refer them to physical therapy? Not necessarily. Sometimes I do. I'm not sure. But I'll send them back to you guys and say, hey, do the non-op stuff, guys. Because this patient's not ready for surgical discussion. Okay? Are we good with this topic now? Any questions about that? Okay. I know it's a topic that comes up. But again, when you're talking about compartment syndrome, do you think you might see a question on PANTS about compartment syndrome? Yes. And it's not going to be exertional necessarily. It'll usually be acute, but you need to understand the difference for your practice and your management of these patients when they present. Because one of the typical patients that I see in the civilian sector, right, when I was an exercise physiologist, they were high-level athletes. They weren't, obviously, door gunners, paratroopers, things like that, right? They were just high-level athletes. So for them to not be able to perform at a high level meant that they couldn't pursue their lifelong dream of going to the Olympics, for example, right? So there's a difference in populations there. Make sense? Okay, CRPS, CRPS, complex regional pain syndrome. Okay, this will be the bane of some of y'all's existence, depending on where you work, but it is something that exists and you need to be aware of it, okay? So when we talk about CRPS, chronic regional pain syndrome, sometimes it's referred to as reflex sympathetic dystrophy. I think the reflex, the RSD actually leans more into what's going on here, right? Because there is sometimes with this sympathetic dystrophy, there is not a clear cause, okay? But it is a clinical diagnosis of pain, altered sensation, circulatory disturbances, trophic changes, and functional impairment, right? So these patients are going to present with multiple symptoms or multiple complaints, correct? It won't just be pain. That's why the word complex is in there, okay? Oligodystrophy, right? What is that? Burning pain. That's that burning, searing pain. Okay, so that's going to be, it's not just going to be pain. They're going to say, I have burning pain, okay? There are two different kinds, when we talk about crips, there's two different kinds, two different major categories, I would say. Type 1 is there's no identifiable nerve injury, right? There's no real cause to hang your head on. And type 2 means that there's nerve lesions, okay? That nerve lesions exist. It is called a rare condition, okay? Somebody in here is doing their CI project on crips-ish type topic, okay? And they realized that it doesn't seem rare because the population that those studies are done on normally is in upper extremity hand, right? And crips exist a lot in hand, right? Hand and wrist, okay, when it comes to orthopedics. But as a whole, it is not a common condition, okay? In subsets, yes, it's common, but as a whole, it's a rare condition. But, and I'm not picking on any one group, but this is the literature, this is the meta-analysis. Women, smokers, 30 to 50 years old. Okay? Women, smokers, 30 to 50 years old. Let's take a pause for a second and think about this. Is smoking a cause of vascular changes peripherally? Yes. Is it a cause of intermittent paresthesias? Yes. That intermittent, the smoking can sometimes, you guys already know about Raynaud's phenomenon, right? Okay. Intermittent vascular color changes, and they can be associated with numbness and tingling. So just understand that can live in this area too. Don't be quick to dismiss something as just simply Raynaud's, okay? Especially since I just told you that it's smokers, right? Let me ask you a question. So do you guys think that if you call me on the phone and you have a patient with wrist or a hand concern for crips, that I'm going to ask you if they're a smoker? I'm going to ask you. Right, so that's an important feature for orthopedics to make sure you get that in history and physical. Okay, it's an important period, but I'm just telling you, if they're a heavy smoker, especially, we'll be less apt to offer them certain surgical interventions until they at least cut down, if not quit. Right, because if they cut down and then ultimately hopefully quit, right, and their symptoms go away, there you go. Okay, makes sense. So again, clinical symptoms, that burning, searing, nerve pain, that's the hallmark, okay? So if I was gonna burn and sear anything into my brain, is that burning and searing pain goes with crips. So if you're given a vignette on pants and it leads you down that road, and oh, by the way, the patient had a previous history of a wrist injury that was untreated, maybe that's where you head, right? So hyperpathia, that pain extends beyond the normal nerve distribution. So we're going to get into a little bit more next week, and then you guys will also get into in neurology that certain nerve roots have certain distributions, correct? You already know this, right? But I'm just telling you that this is pain that's out of proportion and it's out of character for the normal nerve distributions, okay? So that's a hyperpathia. And hyperesthesia. What is hyperesthesia? So it's a heightened sense of sensation, right? So you just lightly touch someone's arm, and that causes that burning, searing pain, right? Or you don't have to do compression of that area. You just light touch, and then they have pain. So is that another form of pain out of proportion? It is, okay? So there is a nice little description there that kind of goes into it, okay? It doesn't talk necessarily about any one area. But when you look on there too, you see things like swelling. So they'll have intermittent swelling, intermittent vascular changes, that's algodynia, the hyperesthesia, right? Remember the word complex is in there? So there's a lot going on. They can also have skin changes, right? You see up there on the right where it says, down at the bottom there it says no hair or nail growth, so they can have changes in skin and nail, okay? So does that lend itself towards a vascular nature versus a neurologic nature as well? It does. You guys talked about vascular claudication yet? Neurogenic claudication? No? We'll get into it a little bit. Okay? You'll get it in other courses as well. But that's what we're talking about is those vascular changes and those neurologic changes that have reciprocal changes in hair distribution. Okay, when you guys were doing clinical skills though, you did talk about looking at hair, right? Remember that? Oh, that was so long ago there. Yeah. So this is, if you look at the leg on the left there versus the leg on the right, it doesn't look the same, right? Does that mean that this leg is like that at all times? No. It can get to this state where it's swollen compared to the contralateral side. You have the vascular changes there. They're reporting numbness and tingling. It may be intermittent, right? Remember the difference between numbness and tingling and numbness, right? Numbness is worse, right? They can have that cyanosis, flushing, increased or decreased skin temperature. So there's that skin temperature change that goes with it too, right? You take the back of your hand, you feel there, right? And you're like, oh, that feels a little different than the other side. Okay? Make sense? Right? So this is all physical exam stuff, right? Pseudomotor changes, edema, abnormally moist or dry skin, right? Odor or trophic changes, they can have unexplained weakness, tremors, muscle bulk changes. What else does it say there? Thin skin, changes in nail texture, and osteoporosis. The osteoporosis is obviously going to be from the long-standing, correct? That's going to be more of a long-standing finding. So just understand that, again, it's called complex regional pain syndrome for a reason. There's not any one thing that defines it sometimes, okay? So treatment for this, okay, this is where, when you guys get it, you guys got an intro yesterday to a farm? Yeah, okay, so you guys will get into the medications here soon. But the treatment for this is going to be multifactorial, okay? Because, like I told you before, there's a lot going on here, right? My therapy is some kind of psychosocial or mental component to this as well. Absolutely 100%. And that may not just be because the patient's experiencing these symptoms, it may just be part of a larger diagnosis, okay? But the mainstay for this is going to be gabapentin, right? What else does it say there? Pregabalin, right? So Neurontin. So gabapentin and Neurontin, right? So for now, I want you to know gabapentin or pregabalin, okay? Just so you guys have that in your radar. Because guess what? Is this nerve pain? It is, right? And do those medications treat nerve pain? They do. They're kind of, like I said, someone here can stand up and quote literature, right? That is the medication of choice for somebody that's exhibiting symptoms of CRIPS, is to start them on low dose and escalate to titrate for effect, titrate for relief of symptoms. Okay? One thing you do need to know about these medications in broad strokes for now is that they're not without side effects. They can make people sleepy, they can make people drowsy, and they can affect motor coordination. Okay? So don't go high, start low and titrate. Okay? Make sense? Right, so physical therapy, occupational therapy. What is the difference between physical therapy and occupational therapy? It's probably a terrible way to sum it up, but I know from my experience, right? When I refer somebody to occupational therapy, they usually have some level of upper extremity issue. Okay, usually it's like elbow down to fingers. Okay, or they have need some kind of rehab to get back to certain activities of life. Okay, because they're the functional rehabilitation, if you will. Is anybody here occupational therapy? Is anybody here physical therapy? No. Nobody wants to fess up. I'll find you. All right, so physical therapy is more so like every body part, right? They do hips, knees, lower back, things like that. Occupational therapy, again, tends to be more focused on upper extremity. Some shoulder, maybe not a lot of shoulder, but some shoulder. So occupational therapy are the people I call on to make those custom hand splints, right? They have all the machinery in their shop. They can make all those custom hand splints for me. They can start people on specific hand therapy to get them back after a fracture or after some kind of injury pattern, get back to their activities of daily life. Other thing they do is like retraining for life, right? So like I said, functional retraining, so they can look at how someone interacts in their household and structure activities that get them back to doing those activities that they do in their household. Okay, yes, that's more civilian type stuff, right? But that's what OT is versus physical therapy, okay? So you're gonna engage with them and they're gonna work with these patients, okay? They're gonna do specific therapies too, desensitization, mobilization, and conditioning. So remember they have that hyperesthesia, right? That super alert sensation feeling, okay? So they have therapy that they do, they're trained on those things. They have sleeves that they put people on, they put sleeves on people, to, because somebody might lightly brush against, what's your last name, sir? Valdez, but lightly brush against them with their forearm, that's where they have their symptoms, and that hurts, right? So if you put a sleeve on there, and start to some of that therapy, that can reduce their symptoms, okay? Or at least make it more tolerable. Okay? So there it is, psych, counseling, coping, and biofeedback, okay? Is there a mental component that goes with this? Oftentimes there is, okay? Even if it's just dealing with the pain aspect of it, right? Sir?
So for the cause then, do they need to have a history of previous injury or does it develop?
I was gonna get into that. Yeah, that's good, because that wasn't in here before. Okay, let me just finish up this part. His question was, do they usually have a causative, like an injury pattern specific to it? And I'll get into that here soon. Okay, that's adding to the slide deck. So, blocks or intrathecal pump. So that's something that anesthesia will normally do. They can actually insert a catheter into a certain body area, and the catheter, the pump, pumps some form of anesthetic or some medication into that area to help them with the pain control. Okay, so that's a very specialized way to do pain control. Okay, so again, another specialty. Okay, the big thing you guys need to understand is success based on timeliness of diagnosis and treatment. So do you think if somebody presents with Crips, you've worked them up, you've rolled everything out, you think they got Crips, do you think that they have a better outcome or a worse outcome if you start, for example, gabapentin sooner? Better, right? Nerves don't take an insult, lightly, right? So they have better outcomes, okay? So before I talked about the referral decisions and red flags, just give you an idea of some of the patients you might see. So like I said, a lot of times it's upper extremity, okay? So they may have those color changes, that hyperesthesia, that nerve pain in the upper extremity, specifically around the forearm, wrist, or hand. And you dig back and you see that they had a history of a fall at some point. Or guess what? They had a distal radius fracture that was managed operatively 2 months ago. And ever since then, they've been having trouble controlling their pain level. Okay? So that's an example of a patient you might see. Okay, that's very common. That's why I want to kind of put that out there. Okay, the book doesn't really talk about that, but that is a very common presentation for this. Okay? And to the point that in hand surgery, when we're doing certain procedures on certain patient populations, what was the population I said?
Smokers.
Smokers, women, 30 to 50, right? We'll just start gabapentin as a post-op treatment. You're like you said, there's side effects. There are, but they're on convalescent leave, correct? Everybody knows what convalescent leave is, right? They're not out there operating heavy machinery or firing a weapon, okay? So there's that time to titrate, okay? So when it comes to those type of patients, a lot of times the hand surgeons I've worked with, we had a protocol. Every patient got started on gabapentin, even if it was low dose, right? But that's where we start, right? Just because we realize that when we're doing these type of surgeries, especially, we're working around a lot of nerves, right? And like I said, nerves don't take an insult lightly. So if we can stave off any progression to Crips in certain patient populations, then we will. Okay, and again, that's why it goes back to making sure that we can get a patient to at least cut down their tobacco use. It can improve their recovery. Okay? Did I answer your question, sir, back there? Okay. So that's one example. Is that all inclusive? No. Because if you go back to this picture, that's the leg, right? Right. So don't lose sight of that. Okay? Because sometimes you won't have a precipitating injury, but you'll have this constellation of symptoms, and you'll start leaning towards Crips as the diagnosis. Okay? If you look down here and you see this tremor, muscle atrophy stuff, tremor, right? We know what tremor is, correct? Right? So that's an indication that there may be more deep-seated neurological involvement. Okay? So maybe, again, you were referring to a neurologist, right? If they have muscle atrophy, is that an early finding or a late finding? Late. So that means you need to refer, again, maybe to a neurologist, right? Because there's something going on here that's been long-standing. Okay? Unfortunately, I will tell you that a lot of the patients, outside of the patients that we treat specifically or directly in orthopedic surgery, there are patients basically from the beginning of their injury. The patients that we have referred have had long-standing symptoms with no formal treatment. Okay, so they can be challenging. Okay, so refer decisions. So when you're going to refer somebody for pain management, are you going to do all that intrathecal pump and all those heavy-hitting meds? No, right? It is fair for you guys to start them on gabapentin though, low dose, correct? And then revert. But if you're thinking to yourself, this patient's had long-standing symptoms and they may need more significant or different pain medications, are you gonna take that on at the primary care level? There's a specialty for that. It's called pain management, right? And not to get harp about orthopedics not being, we don't care about pain. You guys will hear that, right? That's not our specialty. Our specialty is actually causing pain, right? But we are cognizant of the fact that we need to treat pain. But even our pain treatment is very short-lived. Usually when we do surgery on somebody, like a major surgery, they might get pain meds from us for like maybe 6 weeks, maybe 8 weeks for like a total joint. But after that, if they're having significant pain management issues, who do I send them to? Pain management, okay? Because then we start talking about concerns for opioid dependency and things of that nature, right? Maybe they need something I can't provide them. Mental health, if warranted, I would always tell you that you need to make sure you don't have a mental health component to grips. Okay, because they oftentimes will find that there is one. Okay, even if it's, again, dealing with the biofeedback or the pain itself, right? They're experiencing pain, okay? Are we good with that? So red flags, I would say, there really are none here, per se. Just understand that if you have somebody that has long-standing symptoms, you need to be quick to act, because now you're behind, right? We are behind the treatment. Makes sense? And obviously, if you get an x-ray, you're gonna do that. Because they had a fall, let's say 2 or 3 months ago, never got seen, you get an x-ray, and you see a fracture, then you know how to manage that, right? But if we are having this hyperesthesia, this algodynia, all these things, in orthopedics, yeah, we're going to manage the fracture, but we are going to start them on gabapentin post-op. Make sense? Okay. Any questions about that? No? Okay. Crystalline deposition disease. This will go faster. So this is the gout and pseudo-gout. You guys already know about this. You guys are experts, right? Yes? This out? Okay. All right, so gout, inflammation of the joints due to monosodium urate crystals. So those are those gouty crystals, right? So not all patients with hyperuricemia have gout, right? When you guys get into discussion with, in other courses, right, GIGU specifically, you'll start talking about underexcretors of uric acid and overproducers, okay? For the purposes of my course, we're just going to talk about the patient has gout and how do we diagnose it and how do we manage it, at least initially, okay? And I'll talk a little bit about prevention as well. But what is the flip side of that? So pseudogout, otherwise known as CPPD, is calcium pyrophosphate deposition disease, right? So those are different, right? So do you notice how those things aren't yellow or gold, right? They look yellow to me, but yes. So you need to understand the crystals are going to be different, correct? Okay, because guess what? If you do are we going to talk in the next couple of slides about doing analysis of fluid? Yes. So you need to know which one you're talking about if you're talking about gout versus pseudo-gout, right? Pseudo-gout is not just kind of gout. It's not gout. It's pseudo-gout, otherwise known as CPPD. Okay, good to go? Most patients with radiographic evidence of CPPD, though, are asymptomatic, meaning you may find certain things on x-ray that we're going to talk about that you, or the radiologist comments, findings are consistent with CPPD, okay? But gout is something that some of you guys know, right? I don't want you to tell me if you have gout, right? But some of you know that when you see gout, you're like, oh, that looks angry, okay? So gout tends to kind of like declare itself a little bit more. What you guys see up here in this picture, and I have other pictures too, how you can have those deposition of those crystals in a small joint. The great toe tends to be an area where most patients, if not, that's the initial area that most patients have, right? Yes. So do those gout crystals and that inflammation cause destruction? Yes, they can cause bony erosions, right? So does that confuse or cloud the picture with certain conditions that we talked about yesterday, like RA, when we talked about erosions? It does. But just understand that, look at the text of the PANS question, and see what they're giving you as far as lab values. Okay, because if they're giving you gout, they'll give you gout lab values. Okay, they'll be different, right? So don't just, so read the whole question. Okay. So can you have pseudo-gout? What joint is this right here? Knee, correct? Okay, so pseudo-gout, a lot of times we'll see it in the knee. Not exclusively, but again, you'll see it's, you okay with it? Yeah, okay, good. And down, water down. So when we're talking about clinical symptoms, right, and this is more so with gout, you can have episodic severe pain, red swollen joint, right? So CPPD, can it lead to that? Yes. But again, like I told you before, most patients stay asymptomatic. So when you see a red, hot, swollen joint, what's in your differential as well? Septic, infection, right? So don't lose sight of that. So with gout, the first metatarsal phalangeal joint is most notably found in initial presentation for patients as well. That's that little buzzword, podagra, right? When we talk about podagra, that is the first MTP. Okay, so when you see a clinical presentation on PANS of podagra, or it says the patient has podagra, right? 50% of initial episodes for gout are that, okay? Followed by knee, ankle, and tarsal joint, okay? So that's ankle, correct? Okay. It can be confused with septic joint. Please don't be the one to confuse it with septic joint. And uric acid levels often low in acute event. How does that make sense, right? So is that uric acid levels in the joint or in the serum? Okay, you guys are ahead of the curve. When you read a question, understand whether it's aspiration analysis. You guys know what an aspiration is, right? You're taking fluid, you're doing a knee tap, for example, taking fluid out of the knee. You're tapping a toe, right? Taking fluid out of the MTP. Do not confuse for purposes of my course or in PANS. Read the question, understand whether they're giving you fluid analysis or they're giving you serum analysis, okay? So you guys are aware that PANS gives you normal lab values? Has anybody told you that, yeah? Yes, they do. There's a little tab you click on, okay? And it gives you normal values. Okay? So you're like, oh, shoot, I haven't memorized those. Yeah, well, for IPAP you do, but for PANS, hopefully, I can help you guys as you progress a little bit more. I just took my boards, right? Right, so I'm primed, right? Because you gotta be quick. You gotta have, open that window. Okay, what's normal? Okay, go back to the question. What does it say? Okay, I'm good. That was not abnormal, right? So you gotta be quick about that, right? So that's a skill. All right, anyways, I digress. Pseudo-gout. Again, pseudo-gout can be asymptomatic, but it can present in acute or subacute attacks, but that's usually just in one joint. So it may be, for example, we talked about a knee joint, correct? Okay. So knee, 50%. Knee, 50%. Knee, 50%. But sometimes it can be confused with RA, right? Just because it's kind of that atypical presentation. But did we already discuss that RA is normally symmetric? All right. So again, that tends to lend itself more towards the presentation and not necessarily the distribution. Okay. So adverse outcomes of disease, if they have gout, right, they can have neuropathy and renal stones due to what? That hyperuricemia. So then you got another case of involvement there, right? So if you have somebody that presents with a history of gout, but now they're having flank pain, right? Could they have a stone? Yes. So don't lose sight of what you're doing. Okay. These little pictures here are meant to kind of illustrate some things. You see this thing where it says chondrocalcinosis there? Okay, chondrocalcinosis. If we go back here, calcium, pyrophosphate, pseudo-gout. If we go here, we talk about chondrocalcinosis, right? Do those two things go together? They do. That's what that's getting at. That's that chondro is that cartilage, right? So for example, here, you see that white stripe there? Right? Do you normally see soft tissue on an x-ray? No, but now you can see it because it has chondrocalcinosis. That is CPPD, guys. That is the distinguishing factor of CPPD. And again, what percentage is it in the knee? Okay, so that may be pathognomonic, hallmark, however you want to look at that. Okay, good to go? All right, so those are those gouty tophi, right? Those are those areas where the uric acid crystals have actually deposited, right? And they're causing that appearance. Okay, so that is the uric acid crystals that have been deposited. You can find them in multiple areas. They can, if they have them like this, they're usually markedly tender. They can have swelling, erythema, and limited range of motion. Do you think with the amount of gouty tophi that they have there, that they're going to have trouble flexing and extending? Yes, they're going to have a lot of tenderness there. Okay, so again, this is pathognomonic. What is this called again? Podagra. Good. There's another picture of it. That doesn't look too angry, right? I get calls a lot of times as ortho. I'll let you guys go break in a second. And saying, hey, I think we need to tap this, and I say, why? Do you hate the patient? Like, do you think that me sticking a needle may be worse than the pain they're experiencing just with that presentation? That may be worse, right? Because I have to take fluid out, and then, because can I put a steroid injection into that capsule there? No, it's already full, guys, right? So I have to take fluid out to then put fluid back in, right? That doesn't sound too good to me, okay? So again, understand, we'll talk about that here after the break, about the treatment, okay? Let's take a 10, come back and talk now.
All you're doing is call me from my arrow.
Although it's a lot of sugar. I just get like fruits and like I didn't get anything. Yeah. Applesauce and applesauce and like hash browns. I got a little pancake. Yeah.
Birthday, Kyle. That sounds so hot. I did not say that. I said, what the morning?
You're in an OR. You can do
general anesthesia on somebody for doing a vest shot. But like in emergency, you and I are 1% later. And if you have a bedazzlement, if you have a benzone and all that, they only be in that's it. Could you imagine being someone lucid and watching somebody just right down your shin bone? Like, I look at the patterns too of it. You're going right into your shin on either side of it, right down the side right here. Imagine being somewhat lucid. The guy just jabbed you once in a while. Like, freaking. I'd probably pass out just watching. I might pass out as a physician. Yeah. So sorry. So sorry. Let me just continue. That will not be Nobody said the winter.
I was going on
You gotta think about that muscle in that capsule right there is such a good thing. When his foot got landed directly on his right hip. Significant amount of pain.
That's a trifecta right there. Sometimes people have to and then the self-belief.
But our last semester, huge thing is balance. You'll make me coming over here for Houston.
I've been leaning on it like as my main search engine ever since I've been here. I can't just do something anymore. It makes me mad when it's really good. Thing that I am expecting is I get nervous about how I do this to AI, but obviously AI is influenced by those who are creating it, right? They probably search for certain parameters, like certain things you can't search. Or like, hey, I can't give that to you, or like search something about like holistics, and it will like figure out who you are. Hey, I can't give you that information. Whatever. And it was about the pushing people. That's one thing that makes me nervous. Like, I guess you can get that with any Google search, especially because it just gives you such a cut and dry thing. They decide to check the parameters more on it, and the correct answer is now
Fire like ball chair.
You know, it just wasn't doing it for me.
what you want you to do. Like she has
couldn't find like the rhythm.
and like during pregnancy.
Maybe that's part of it. Just keep moving that way, but
And like I was doing the chest, the drops,
no, I don't know. That might be my 1,500 or 1,700 chair.
You have a 40 chair.
Yeah, honestly, I know it's a lot, but I don't know. When I went on vacation in Poland, I brought a little grinder and pour over kit. I like this read the name, but it's like a material, plastic. It's like rubber but plastic. But I could like extend it and I put like my little filter in.
Oh yeah, I know exactly what you're talking about.
And I brought that with me, and people were like, so extra. I mean, yeah, but it's my thing.
Yeah.
You guys,
You guys do all your. I did the same shit in Poland. When I go to I would always bring at least 2 things. I would bring my little camping stuff, and then I would bring my mocha pot, then coffee. I would just put that over the flame, water, and coffee. So I make fresh coffee every morning after dinner, and then
the powder stuff.
we have a whole A station set up here, like at the
Where in Poland were you?
in Corn. So that's always where they send artillery. They have a base there. It's called like Camp St. Barb. Okay. St. Barb because the page is St. Artillery. Like legit, like every year artillery units have the St. Barb's Ball where they go. And it's only like senior NCOs and officers and them hyping each other up and some officer or senior units go to St. Barbara.
Yeah.
But yeah, it's like right. It's a little mid-north. It's about an hour and a half south of Dansk.
I've been in
yeah, whatever it's called.
That's cool.
But like, it's a really nice town. Like, it's a small little medieval town. Like, you're literally right outside, like the outside of town. Like taxis are like little strip club out there. It's like $5 to get like the middle downtown.
I was only there for 2 months.
So good. But that was all AI. I was like, hey,
I don't even
and it gave me
probably the new way to
Yeah, I went there when we were in Poland like 6-7 months, something like that. Went there, went to Pozniak, went to I haven't been, it's like 2020. Like because we did both Germany and we had the first part in Germany and the first part. We went graphic here, and then Poland were JMRC and like after the JMRC and we packed it together.
Because I just lost one of my.
So like the whole brigade was together.
down to half of my order.
And exactly all individuals. One went to so we're all like spread apart like water, and then just working along with just terrible, just like the Polish, like no time we ever saw like other marine assets. So we just like the trade station, like but I also we had like regular care and stuff. So like they threw us like I was like they somehow made it. So I didn't do I was like why? Because they have no sense of like patient privacy. So you're sitting there, like, it's not nice to go in the hallway. Like, they're like, yeah, that's going on, that's going on. We talked like that, their chief surgeon, like, and he's all like, yeah, I'm jealous of Americans because, like, his salary as like a 20 plus surgeon
To go line. Yeah.
is like 18,000 US. Yeah, because like so they'll get paid like everything, so then they're like whole Turkish.
That's true.
But like it's socialized medicine, so like they don't have doctors, nurses, like they don't make a lot of money.
Yeah. Interesting.
And peanut butter's good. Although the one that I got.
So what was
Alright,
that?
let's get started. Alright. Good questions, okay? I encourage questions. In case you guys didn't hear this already, I can't remember if I said this yesterday, but I built a whole other period of construction into this course. So never feel like we're behind. We're right at the sweet spot, right? Because we want to make sure that as we progress, that we're getting these topics, because it's coming fast, isn't it? Right? And that way, when we circle back and test review, it's not the first time you're actually reading the slides and trying to understand them. Okay? Good to go? All right. So, what are you going to see radiographically? So, gout, that's a soft contour erosions, but that goes with something else too, right? But if you see what? Periarticular spurs, does that go with anything else? You're saying yes. What else does it go with? It is osteoarthritis. You're correct. Thank you. Right? So, periarticular spurs, excuse me. But, let me ask you this question. Do they go together? And in osteoarthritis, do you have erosions? No. So that's how you differentiate that. Okay? Thank you. I love it. I love participation because I hope you never feel like I'm picking on you. I'm just using your excellent analysis to progress our learning. Okay?
Sir?
Yes, sir.
Did you say that there was no erosion in osteoarthritis?
Correct. By definition. Can you have degeneration? Yes, but we don't use the word erosion. Erosions dictates that there's an inflammatory process that is eroding. Is osteoarthritis an inflammatory condition? No. Can it have inflammation? Yes. Inflammatory arthritises are RA, for example. Right? That's the big one we talk about. Because those are due to systemic autoimmune disease, correct? So your body, who hates you?
The body.
You, right? So your body is trying to destroy yourself, right? So, makes sense? Thank you for applying. Appreciate it. All right, so pseudogout, that is chondrocalcinosis, correct? CPPD, right? What's the one in yellow? Meniscus. So chondrocalcinosis of the meniscus is pseudogout. You guys see that picture right there? Right there? Okay, see there's two freaking arrows, right? Should you be able to see the meniscus on a plain film radiograph? No. Dog mark? That was good, sir. I appreciate that. So, yes. So it's let me get myself back on track. So meniscus, right? So if you see a chondrocalcinosis of the meniscus on a radiograph, what condition do you automatically think? Pseudogout. Okay. TFCC. Okay. Triangular fibrocartilage complex. That is your wrist. Right. So you have TFCC. We'll get into that next block, but it can also be found there. Okay. That means that triangle becomes a triangle that you can see on radiograph. Imagine that, right? That's not normal, correct? But what's the only one that's in yellow? Meniscus, okay? Because that's the one high probability that you might see that on a pants question, okay? Good to go, okay? So when we talk about these changes here, does that look like it's long-standing podagra? Right? It can come and go, right? But you see some changes there. Some of that erosions, right? Some of those erosions and those periarticular spurs. Okay, can it affect other joints? Yeah, it can. Okay, so make sure again, and somebody brought this up earlier, when we were talking about RA, I never want you, unless you see me tell you, do this first, do that second, you're just doing all the labs. And then you're laying it out again and figuring out what do I got. Does that make sense? It's not like, I'm only going to do inflammatory markers, if those are normal, then I'm doing. No, you're going to do all the labs I'm talking to you about. Okay, make sense? Okay. All right. So diagnostic test, quickly. Gout, negative birefringent needles. If you can't wake up from a dead sleep and figure out that's gout, get that in your brain. Okay? Because what is the positive birefringent? pseudo-gout. Okay, I highlighted those. One's in bold gold, the other one's in red, angry red, I guess. But that's just to differentiate that there's a difference. They're diagnostically, again, they're different. Okay, so elevated ESR CRP, does those tell you it is gout? Okay, no, because you can have inflammation due to a number of reasons. Infection, for example. Okay, serum white blood cell count, can you have an elevated white blood cell count in other conditions? Okay, yes. So a lot of times, and somebody asked this question like on break, like a lot of times, you know, the rheumatologist or providers that are treating this will do an aspiration, okay? And then, do you think that those needles that you're seeing, whether they're positive or negative birefringent, that you're seeing those under a microscope? Yes, so that's part of your serum analysis, okay? So then you're looking at other things like glucose, right? RBCs, right? Is there evidence of bleeding? Okay, things like that. So again, you're doing kind of all of that to make the diagnosis, right? Now, having said that, do you think if I saw this angry toe again like this, I'm going to just tap it to figure out if it's gout? I'm going to treat it as if it is gout based on the patient factors, okay, and the fact that there's no concern for infection. Make sense? Because guess what? Do these patients also have a history? They do, right? Are they supposed to drink and eat certain things in their life? No. So if they have high diets in those areas and they've been diagnosed previously, and now they have this red, swollen, angry first MTP, I'm not going to do an aspirate to figure it out. So when we're talking about doing this may be kind of the initial diagnosis period, okay? Does that make sense? Okay. So it's not necessarily every single time a patient comes to your clinic, you're going to tap it, right? Everybody knows what I mean by tap it, right? That's great. No, unless you hate the patient, right? So how do we treat it? All right, before we treat it, let's get to this little chart here. I think this is helpful here, okay? Hope memorize this chart if you don't already know these factors. But just see that also there that now maybe you haven't seen the radiographic findings, right? So add that to your repertoire of knowledge, okay? Because if you see a chondrocalcinosis of the meniscus, that goes to CPPD, correct? If you see those erosions and those periarticular spurs, and you have positively birefringent crystals under microscopy, you're thinking gout, right? Okay. I lost people. All right, so initial treatment, again, this is all non-operative management, right? So initial treatment, NSAIDs, indomethacin tends to be the one, okay? And the company, I don't know, I can't remember what company, but whatever company made indomethacin, this is where they make their money, at least initially. Okay, now they're in like, you know, third, fourth revisions, they don't make it much. But so indomethacin is a mainstay for initial treatment. Are we talking about a gout attack? Yes, okay? And that goes with colchicine too. Okay, so those two are kind of initial treatment, indomethacin and colchicine. Okay, I will again not test you on dosages, etc., because you haven't had that yet, correct? So you will not see that on my tests in the form of me asking you specific dosages. Okay, but I do want you to know what's used to treat acute gout. Good to go? Okay, indomethacin, colchicine. Now later on, once the acute phase is done, right? Then, and see how this is 1, 2, 3, 4, right? Later on, once the acute phase is done, then you're talking about probenecid or allopurinol, okay? Those two medications you'll learn about, those are used to prevent future gouty flares. Okay, so that's more in the maintenance phase, prevention and maintenance, okay? But still, if the patient's taking allopurinol or probenecid, is anybody here from the Pacific Rim, Hawaii, Guam specifically? So they love the pork, they love the beer. I do too. But there's certain foods that they shouldn't eat. And they, even though they're on medications and told to manage their diet, they don't. So they usually come with a history of, we had a Christmas feast, and Monday morning I woke up with a red, angry, swollen toe. Okay, even though they've been taking the meds. I'm not joking. I like those foods too. So, but they need to understand that even with the medications, they can have flares, okay? For non-operative pseudogout treatment, or NSAIDs or colchicine, again, did I tell you that most patients are asymptomatic? I did, right? So when I get a patient that comes in for a knee complaint, right, and I get an MRI, and the radiologist comments on findings consistent with CPPD, do I do anything about it? No, because they are having issues with their ACL, for example, or something else, right? So it doesn't necessarily necessitate treatment. But if they are symptomatic, sometimes after we do the NSAIDs, we can consider a steroid injection. Because are you going to go in there and start chopping this guy out? No, they need those. Those are shock absorbers, right? So maybe something to temporize their pain until they improve, get the swelling down, and go on with their lives. Okay? Make sense? I know it says weekly positive there. Okay, positive. Good. Don't get in the weeds about that. Any questions about that? All right, this is gonna be quick. How many times have you guys heard about DVT? 1,000 times. Broca's triad, what is it? Stasis, and intimal something. Damage, correct? All right, you need to know that, okay? DVT, there it is. Hypercoagulable state, which one of those is the most important to know? We'll tell you at this point in your education, just know all three, okay? There are some that are modifiable, obviously. So, history of mobilization. This is a surgery class, correct? It's called orthopedics. What is my title? Orthopedic surgery PA, right? Do I just do non-operative orthopedics? No. So therefore, you need to understand that the reason this is thrown in here is because in my world, if a patient has a history of surgery within a week or two preceding their presentation of their calf swelling and their redness, then I'm concerned about DVT secondary to immobilization after surgery. Exactly. Yeah. So, but they can also have long flights, long car rides. Hans loves to tell you that somebody's a flight attendant or something like that, right? They were on a 6-hour flight. They're just look for it. All right, look for the answer, right? Because that's if you're heading that direction. But I'm just telling you that for the purposes of my course, I'm going to ask you about periods of immobilization. Right, if somebody's put on crutches, are they putting the normal venous pump, the normal venous return into the lower extremity? No, so they can predispose them. Is that a stasis? Is that a hypercoagulable inducing state? And do they have a form of a form of decreased mobilization? Yes, and those all precede that. Okay, those are risk factors is what I'm saying. Okay, so clinical symptoms. A lot of times DVTs, right? You think to yourself, I don't think this is a DVT, right? And you send your patient on their way, they do just fine, right? But it's unrecognized in 2/3 of cases, right? So what does that mean? Maybe you haven't seen it, but it has seen you, right? And the patient did just fine. But for that 1/3, right, what are they going to have? They're going to have swollen limb with severe pain. Lower extremity is much more common than upper. I don't know anybody that walks on their hands. Maybe you guys do. Good for you. But I'm just saying the ability to limit that venous return in the lower extremity is significant. Everybody knows what I mean by venous return, right? Unexplained fever or leukocytosis after surgery. So fever of unknown origin, when you guys get into surgery next semester, you're going to hate that subject. That's just, maybe, probably, because there's a lot. You got to work it up, right? But if they have unknown fever and or leukocytosis following surgery, you need to work it up because that's not normal. Okay, Homing it there. Homan sign. Is this how you guys were taught to do Homans? The legs straight and just dorsiflexing at the ankle. How were you guys taught? You have not been taught. Good. So I can teach you the right way to do it. Okay, so you can do it like this, okay? I will tell you that this is actually the preferred way of doing it. So basically what you do is that you have the patient laying flat on the table, right, fully supported, relaxed, right, not doing the half crunch. Everybody wants to see what's going on down there. Not doing the half crunch, relaxed, laying down, and you literally take your hand, put it on their calf, and you take your other hand, right, depending on the leg, right, and you do what's shown in this picture. You see how he's supporting the calcaneus, the heel, and he's using the meaty part of his hand to dorsiflex there as well. Okay, that gives you a little bit more control. And they're reporting the pain specifically more proximal about the mid-calf region. That is a Holman sign, okay? Because if you put a stretch there, right, and you don't do it correctly, could that also be an indication of an Achilles tendon injury? It can be. So therefore, you have to differentiate the two. And we'll get into Achilles tendon injuries in another block, right? But for now, this is how you do the test. Can you do this test? Yes, sir. What kind of pain? So basically, they localize that pain. So his question was, what kind of pain was it? So they localize the pain to the calf region or more proximal. Yes, it's right there, right? So because we're talking about DVT, not PE, correct? You guys understand that's a spectrum, right? We're talking about DVT. So they can have redness, they can have swelling, but believe it or not, it may not be profound. Okay? Has anybody here had a DVT that wants to share? Right? It's not uncommon in the population, right? But anyways, so basically, like I said, if they have that pain that's localized to that region, it's a DVT until otherwise proven. Okay? Do you wait for them to have respiratory issues to start working this up? No, they have a history of prolonged immobilization. They're post-op, correct? Right? So it's a DVT until otherwise proven. You guys are starting to share in my paranoia. Okay? So the test, historically most common test, this is still what PAMS thinks, right? Phenography, contrasted CT. You shoot contrast, you do CT. Are we going to other modalities? Yes, we are, okay? But that's still considered kind of the gold standard, okay? Shoot a dye, take a look at it, okay? Have we made a shift now, more so in clinical practice, to ultrasonography? Yes. Less invasive. Does that dye that you inject, does that have a load on the kidneys? It does. Is it technically invasive then? It is. But if you can slap an ultrasound on there and do your evaluation at bedside, that both saves the patient some discomfort, right? Doesn't bag the kidneys as much, and also gives you a quicker read, right? Because you have to wait for that dye to kind of run its course and then do the CT. You do, right? So especially if time is an issue. The problem with ultrasound, is anybody here an ultrasound tech? Somebody is. I'll find you. All right, so the problem with ultrasound though is it's operator dependent, right? So if you're not 100% sure what you're doing, you should let someone else do it that you trust, right? Because it is operator dependent. How you put that probe on there, you guys are going to do that in senior semester, you know that? You guys are going to do ultrasound stuff, okay? It's going to be cool, awesome, right? But you're looking for this. This is on, but is this on an ultrasound or is this on a CT? That's the CT, right? The dye doesn't go where it's supposed to go, right? But if you go right here, you're looking for you're compressing the blood vessels and you're looking to see for that venous return, right? For that reciprocal change there, right? Do you put a setting, do you push a little button that changes it to red and blue so you can see the blood flow as well? Yes, you do. Again, not getting too much into the weeds about ultrasound, but I'm just trying to give you guys a sense. It's a skill set. If you don't have it, don't try to represent it, basically. Make sense? Okay, but again, I will tell you, for the purposes of PANS, they're still going with venography, okay? Contrast CT, okay? Questions about that? All right, so what's a PE? Breaks loose, goes to the pulmonary vasculature, correct? Okay, so there's the hypoxia, right? There's the tachy's, there's the chest pain, right? Hopefully you don't get to this point, right? So tachy, chest pain, occasional hemoptysis. Okay, things are backing up, right? So if the blood starts backing up into the lungs, where is it going to want to come out at? Path of least resistance. That's correct. Okay, so tachy, chest pain, and occasional hemoptysis. Okay, you should burn that into your brain. Right? CT pulmonary angiography is still the most currently validated test. Okay, so again, CT pulmonary angiography. See this nice? It looks like a tree, right? Sprouting tree or a bush, something like that. So that's where you wait to see and see where all those blood vessels go. Do they go where they're supposed to go? Okay? Who treats this? Ortho? Heck no. Right? It's Pullman. I told you guys yesterday, we don't work in a kill box. Okay? So this is again going to be cardiothoracic, vascular, general surgery. We punt as fast as possible. Okay? But in our clinic, we do ultrasounds, right? This is going to confuse you. Let's just say we do venography, right? We do venography CT, right? Because that's the gold standard, right? But whatever we do to work it out, if we realize, okay, now this patient is more hemodynamically unstable, they're out of our clinic. Otherwise, when you guys go into pharmacology, you'll start talking about the treatment for PE as far as the medications. Okay? Good to go? Are you guys satiated, at least for now? Okay. So prophylaxis. So prophylaxis means we're trying to prevent things, right? Okay, so DVT prophylaxis, you'll hear us commonly talk about that in the surgery world, right? So mechanical is literally what it sounds like. You see that sleeve that you put on the lower extremity? Remember how I talked about that pump, that venous return? That's what that's doing. It's mechanically doing that, okay? So hopefully it prevents clots from forming. These sleeves, one's on the lower extremity there, one's on the foot, right? There's different kinds, okay? So those will periodically go off in the middle of our surgery, right? Just to keep things moving, no pun intended, right? Can we put that on the operative side? We're doing an Achilles tendon repair? No, it's in our whole way, right? But it's to hopefully prevent clot formation on the other side, okay? A chemical prophylaxis, my chemical, your chemical, medications, right? Those are medications meant to do the same thing, prevent clots from forming. The one I want you guys to focus on for now, at least as a class or a type, right? Not dosages again, right? Is heparin and enoxaparin, right? Heparin more so IV, right? And enoxaparin you can do injections, okay? Those are quickly reversible too, okay? Warfarin, aspirin. Do we do a lot of aspirin in orthopedics? We do, right? No, we start a lot of people on aspirin, okay? But the big thing about this is now we know the patient has a DVT, we're going to focus more on heparin and enoxaparin. Good to go? Aspirin is not uncommon, right? Can you turn aspirin off quickly? You don't know the answer yet. No. Yeah, there's a washout if you will. Okay, good to go? All right, again, not me, right? All those plasties, we don't do. Angioplasties, we don't do it. Thrombolysis, we don't do that. Inferior vena cava filter, we don't do that. All right, IVC filter is not our world. This is stuff you're going to look at afterwards, after you've treated the patient properly. Hopefully they don't die, and then you get to this point, okay? All right, so in conclusion, we talked about RA, right? So RA is something I spent a lot of time on. I really slowed down this lecture period. I feel like we went too fast in previous semesters. Spend some time with RA, get to know how it's different than other presentations. That way you know when you have RA. What are those two labs that we talked about? Anti-China? Okay. And that's your position, I think. So anti-CCP and RF for sure. So understand that if you just have RF, is that as strong as having RF and anti-CCP? No. Okay? So understand that. That's an important concept. Okay? Seronegative small arthropathies, know why they're not RA. Okay? And know why they're not, one is not the other. Ankylosing spondylitis, radiographic findings, you must know those. You'll see those in some way, shape, or form. If not on the pack rat, on the pants. Okay? You guys know what a pack rat is yet? Practice hands. The questions are harder. Okay? Compartment syndrome, hopefully I've scared you enough. Right? Don't miss it. Call me. Right? Complex regional pain syndrome, I know I've scared you enough. Because you're like, how am I going to manage that if I can't figure out what's going on with the patient? Good luck. Just understand that it can be multifactorial, therefore it involves a multidisciplinary attack. Okay? Crystalline deposition disease, gout, pseudo-gout. Right? Know those differences. What are the crystals, right? What do they look like in the microscopy? And what do they look like, the differences on radiographic findings? Okay? There you go. Okay. And DVT I just went through. Any questions about that? Okay, we'll start getting into this a little bit. And then what do you guys have next? Pulmonology. Exciting. So ganglia. So what is a ganglia, right? The benign cystic structure right, that exists, and is it fluid filled?
Yes.
Yes. It arises from the joint capsule or tendon sheath. It's filled with synovial joint, right? The fluid is often clear, thick, and mucinous, or mucinous, depending on your presentation. So I call it jelly, because that's what it looks like. A lot of times when I take that jelly out in clinic with a big, large bore needle again, right, I squirt it right on a 4x4 so they can see it. Look at that jelly, right? So think like a jelly donut, right? So, but just understand it's a balloon that forms, right? And that's a one-way valve. Once that fluid gets into that capsule that's now being created, right, it doesn't have a way to get out immediately. Okay? Now, can it, over time, lessen in size? It can. Okay? But what causes it? Degeneration or tearing of the joint capsule or tendon? But a lot of times we don't know. That's the short answer. We don't know. Okay, so sometimes they don't have preceding trauma of any kind that we can discern, and they have ganglia cysts. It's the most common soft tissue mass of the wrist and hand. Age is what? 15 to 40, right? So you guys see that picture there of that balloon, right? What do you think is in that balloon right there? The jelly, okay? And that is a very common site, is the dorsal wrist. I accentuate that because the dorsal wrist, you guys can play a little bit there, right? Do they also get volar wrists? Everybody knows what I mean by volar, right? Palmar side? Yeah, they can, okay? Dorsal is more common, but they can get volar wrist cysts. If I can scare you about one thing today, don't put a needle around a volar ganglion cyst. What major artery lives on the palmar or volar side of your wrist? You bag that artery, we'll be seeing you at disciplinary review, right? Because there is going to be bleeding, right? And there's going to be pumping bleeding. It's not going to be a venous bleed, right? So it's going to have to stop. All bleeding stops eventually, right? But hopefully before the patient dies, correct? So don't do it. Okay? All right, so there's another picture describing some of the areas you'll see it, right? So again, dorsal wrist, volar wrist. You can see it in the flexor tendon side. You can see it in the distal phalanges, okay? So I would tell you the distal phalanges, even though it's included under ganglia, they're usually, those tend to be treated differently, okay? Those tend to be mucus cysts, okay? And they tend to occur at the DIP. And those are cysts, right? Not to be confused with Heberdine's nodes, correct? These are different. These are cysts. These are fluid filled, okay? Good to go? All right. So knee, the one thing we'll talk about for the knee, where's the popliteal fossa? Is that the anterior knee or the posterior knee? So therefore, they're called popliteal cysts, okay? What nerves and other structures live in the popliteal fossa? A lot. And another big artery, right? You want to go poking needles in there? No, don't do it, right? I will tell you that even in my specialty, we don't necessarily do it unless we're doing it ultrasound guided. That's a bad thing, okay? If you bag anything that you shouldn't be messing with, okay? So don't do it. You see this Baker cyst there? Do you think that's representative of what you'll see in clinic? No. So you can have a lot of fluid back there before you actually see it from a distance. So I will tell you that you may actually order an MRI for something else, some other condition, an ACL tear, and they'll make comment that the patient has a popliteal cyst. Do you think you're going to make any mention of it to your patient? You can. Be weird. But that's not their concern, because they're not complaining of pain back there. They're not complaining of swelling back there, correct? So I will tell you, I had a preceptor that told me when I was a PA student, don't go where you're not invited. Okay? But having said that, again, you may find that as an incidental finding. Okay? Good to go? All right. Foot, usually they're on a dorsal aspect. I have a picture on my phone. At some point, obviously not during class, it's not show and tell, but big dorsal foot ganglion cyst. And I'm like, dude, how have you put a shoe on for the last 2 years? And he's like, oh, I don't really wear shoes. I'm like, you're in the Navy. What do you mean you wear boots? He's like, I'm a dive blocker and all, yeah, this crazy story, but I'm like, it's pretty significant, right? So they can get pretty big before people present with those. Are you gonna go cutting those out in clinic? No, because you don't know what else is involved there. Okay, but just understand the dorsal foot cysts, they can be pretty impressive by the time patients come see you, right? So he absolutely could not push you on at that point. So, yeah, crazy stuff, man. So mass, it may or may not be painful, believe it or not. Is it inflammation though? No, it's just a cyst, right? It's a pocket of mucus fluid. So it may not necessarily be painful, because it's not inflammatory, correct? Right? Now, when does it become painful? Say it's dorsal wrist. Everybody, I'm assuming here, has done at least 10 push-ups in their life, okay? So if you put your wrist into extreme extension, right? Do you think that might compress that dorsal ganglion cyst? Yes. Same thing conversely with the polar ganglion cyst, because you're literally putting pressure directly onto it potentially as you're doing push-ups. So that may be what you hear, okay? But for the most part, when you're looking on physical exam, you're going to see it right at the center of the dorsum of the wrist, okay? We'll get into scaphoid. You guys know what a scaphoid is, right? So, but that scaphoid, the bone next to it, right, it's called the lunate, correct? So that's that scapholunate interval. Usually it kind of lives in that area. So it's thought that there's some kind of a tear on the capsule there. But again, sometimes you may not know the cause. But that's kind of where it lives, okay? That's where you'll see it, okay? So if it's radial, it's going to be radial volar, So it's going to be more towards the radial side, okay? And then volar, meaning palmar side. Okay, I'll go ahead and get it out of the way right now. You'll hear it again. But when we start talking about upper extremity, especially the elbow down, if you use in terms like medial and lateral, the way I'm walking right now is the way you have to think, right? So when we talk about wrist and hand, we tend to talk about radial and ulnar sided, because we all know what that means. When you look at your hand to talk to a patient about a fracture, you usually do this. Now you won't, because I'm pointing it out, right? But, so don't confuse yourself, because in order to talk about medial and lateral, you would have to do this. Does that make sense? So in radial side, that means the side of the radius, the scaphoid side, the thumb side, however you want to think about it. Okay? So it's radial and volar. That perfectly describes where the radial artery is, correct? So don't be that person. Okay? Fingers, mucus cyst, dorsum of the finger, distal to the DIP. So they're not going to actually be at the joint line sometimes. It's just distal to the distal interphalangeal joint. Okay, and it's going to feel like a fluid-filled cyst. Don't go cutting those open, scratching them up and all that. They have a high likelihood of infection and a recurrence as well. So, okay, everybody clear on that one? Good. So mass effect, what is mass effect? Now, you gamers out there, no, I'm not talking about that. Okay, not the video game. Mass effect literally means that there is something that's causing an effect in a given area, right? In this case, it's a mass, right? So if it's a radial artery and it gets large enough, can it affect blood flow? Can it affect, can it cause numbness and tingling in certain distributions? Yes. Okay, so that's mass effect. If it's large enough in the posterior knee, the popliteal fossa, it can affect the tibial nerve. And we'll hit that again. Okay? But what you're going to see, what you're going to document usually is this up here. It is a mass to the dorsum of the wrist that has been waxing and waning in size for 3 months, right? That's kind of your description of it. So it gets bigger and it gets smaller. That's what that means. Remember I told you it's a one-way valve? Well, guess what? Over time, it'll find its way. It's just that you can't express it immediately. Once it swells up like that, it's not like you can just push on it and make it go down. Does that make sense? Okay. Good. All right. So transillumination of the wrist and hand, yep, sure. Can you transilluminate the posterior knee? Tricky, not so much, right? But transillumination is literally a pen light in clinic. You ask yourself, what do I do if I don't have a pen light in clinic? What is that thing hanging on the wall that you stick in people's ears and mouth? A light source, correct? Okay, use that. Okay, so we talked about that these things are fluid filled, jelly. There's jelly in these, right? So if you put the light up to it and you see that it doesn't appear to be fluid filled, but it appears to be solid, is that a ganglion cyst? No, that's the C word to otherwise fluid, right? Make sense? Okay. Remember at the beginning slide it says benign cystic lesion, right? That's what you want to tell your patient, right? You have a benign cystic lesion because they're like, whew, I don't have cancer. Like, because you're going to use words like mass, right? And you're like, mass? I have cancer, right? But you see how this here, does that look solid or does it transilluminate and look clear? Right? One looks solid, one looks clear, right? So those are the differences. And this is a clinical thing. You guys, as you do it in clinic, you're like, oh, that's what he's talking about. It looks like a halo around it, right? And it looks fluid filled. Make sense? So that's what I'm talking about when I'm talking about transillumination. Okay? So, again, the posterior knee, we don't necessarily do it, right? But on physical exam, you're usually going to find the ganglion cyst to be predominantly in the interval. What's the interval it's in? Between the medial gastrocnemius and the semimembranosus. Okay? So the gastrocnemius has a medial and a lateral head, correct? Of course it does, because the answer is yes. But also because you guys are expert anatomy people, right? Don't worry, we'll go through that again. But this is the interval you find it in. So if you were to see a test question that asks you or references the interval it's found in, this would be the answer, correct? Of course it is. Okay? So x-rays, so Major Davos, this is soft tissue, it's a cyst, it's fluid filled, it has jelly in it. Why would I get an x-ray? Why would you get an x-ray? To rule out bony pathology, right? If you look there, you actually see a bone, a fracture, right? That occurred previously that was untreated, right? Remember we talked about scaphoid. Does the scaphoid fracture commonly? Yes. Can you have scapholunate conditions? Yes. We'll get into those. But you're getting x-rays to rule things out, okay? Can you see the swelling on there? You can, okay? You can also see the swelling there. You don't see anything else. So you literally get the x-ray and you make comment of the swelling, the superficial swelling noted, and then you ruled out all other bony pathology. Then, what do we do in surgery world? We like to cut things open, right? We like to cut things out, right? So, do we need to get an ultrasound of it if we do an aspiration of it? Not necessarily, but that's another tool you have, okay? So you can put the ultrasound on it, and can you check with an ultrasound, again, remember this is operator dependent, but can you check with an ultrasound and discern whether something's fluid filled or solid? You can. So very useful, especially at bedside, right? Can be a quick way to alleviate some concerns, okay? But they're more so used for popliteal cysts, and again, we'll circle back to DVTs, right? Okay? Good. You see this picture here? Does that look like a cyst? Yes. Now it looks fluid filled to me. Again, am I going to give you a picture like that? How you discern? I'd have to tell you what settings the ultrasound is on, right? Because there are some things white sometimes and dark and other times. Yes. Okay. So I wouldn't do that, right? Again, getting back to that compression. Do we sometimes get an MRI? Yes. What side is this on? Is this volar or dorsal? Volar. 100% of times we get volar, right? We get an MRI for volar cysts, right? Because we want to know what are we engaged in here? Is it, how close is it to the ring artery? Oh, and by the way, there are some nerves that run there too, right? So is it wrapped around a nerve? You want to know that, okay? Usually with volar ganglion cysts, believe it or not, all orthopedics is not the same. I keep saying that to you guys. We have hand and wrist specialists, right? Maybe they'll do that one. Make sense? We do a lot of dorsals, right? A lot, like all of them. Anyone that comes, right? But volar, you might say, ooh, that one looks like it's engaged in some serious structures there. So you see that area there? So you can discern on MRI what other structures are involved. Okay? So obviously if you have mass effect, can you have weakness? Yes. Can you have paresthesias? Yes. I'm not going to belabor that. Just understand medium and ulnar nerve, you guys, after next week especially, you're going to be living. You're going to wake up thinking about radial, ulnar, and median nerve distributions. Okay? Because we're going to start talking about spine. So I'll save that. But So hand and finger, look at that. Does that look angry? That looks angry, right? Right? So that's somebody messed with that. Right? They poked it and thought if I just poke it and express the fluid, we'll be good. You gotta get all the cyst too. You gotta get the actual capsule too. That's with any cyst. So if you just go nicking something, right, or poking with a needle, it can come back, but more importantly, it can get infected. So when it comes to distal phalanxes, right, and these mucoid cysts, do not treat those in clinic. Refer those. Okay? Make sense? So you see that jelly down there? That does look like jelly, right? You see that needle right there? Is that a large bore needle? We came to party. Right? If you use a small needle, you'll be there until the cows come home. You got to use a large needle. Okay? All right? So I will, again, appropriately consult a patient on risk, benefits, and alternatives. And if they say, well, I want to try an aspiration, I don't want to go right to surgery, that's fair, right? When I pull that jelly out of there, I take a 4x4, right on the, did that come through? Yeah, but that's the sound it makes. So I go ahead and squirt that onto the 4x4 and show the patient. Look, it's jelly. It is a ganglion cyst. Okay? Why? Because it makes it feel good. And I'm all about making patients feel good. Right? But you've done, now do you have to do an aspiration? No. Sometimes they go away on their own. How did we treat this in the biblical times? You hit them with a Bible. Okay, you put their hand, wrist on the table, and you slam a Bible on it, it pops. Okay, so these can go away, right? But the options are the conservative care that's listed there. Immobilized. Is immobilization been shown to do anything other than maybe alleviate some of their pain they're having right then and there? No, it's been shown to do nothing. In fact, and you'll hear me say this in the future, stiffness is the enemy of orthopedics. If you put somebody into a knee brace, on crutches for a prolonged period of time, are they going to get stiff? Heck yeah. Then you got a whole other set of problems to deal with. Okay? But if you choose to move towards a needle aspiration, are you ever going to aspirate on the volar aspect? Never. But if you aspirate on the dorsal aspect, be careful. Okay? Be careful. Be aware of your structures. And again, in the finger, just don't do it. Mucoid cyst, leave them alone. Refer. Knee, how do we do those? If we do those, and whomever does those, ultrasound guided, right? That's what it says there. Okay, there's the awesomeness. Okay, the N, right? Intraneural ganglion cyst. This is the freaking nerve. That is the freaking cyst, right? So, do I want to be poking around that thing in clinic? No. So we got an MRI and we found that. Okay, so that's why it's important to be careful. Surgical excision. When I say excision, I don't just mean you go in there and pop it, right, and suck the jelly out from an open approach. You actually go in there and you remove all the contents of that capsule. If you leave any remnant, it'll come back. Okay? Having said that, could they come back anyways? Sometimes they do. Okay? But here's your numbers. Aspiration, 85 to 90% of the time they come back. And I counsel patients on that before I aspirate. Okay? With excision, though, that's low. 10 to 15%, correct? So what is the preferred treatment? Well, I was surgery, guys. So my preferred treatment is always surgery. But, ma'am.
So do they always come back on the same site, or they come back?
No. Sometimes, that's a good question. So our question is, do they always come back at the same site? So when you see a patient, you need to ask the question too, do you have any other lumps, bumps, or cysts in your body? Some people are cyst makers, right? You guys haven't learned about lipomas yet, but if you got jelly bellies, not jelly-filled cysts, but jelly bellies, right? That fat deposits in other areas, right? So if you got a bunch of lumps and bumps you're going after, there's especially the lumps, bumps, and lumps. This is being recorded, so it'll be nice. But it is called general surgery. We are not general surgery. So you need to ask the patient that, okay? Just because they have a cyst in one area that they come see me about, I ask them that question, and I'm like, you got a bunch of bumps and lumps. You got to go see someone before we can address that. Because there may be an underlying fat deposition disease going on. That was nice, right? So there we go. So the digital nerves, do you guys know what the digital nerves are? You got 1, It runs on the radial aspect. You see how I'm doing that without even looking? Because I know my radius is out here. The radial aspect and the ulnar aspect of every finger has a nerve. All right, so you start blindly cutting into the finger, you can cause some permanent numbness. Notice I said numbness, right? Not paresthesia. Okay, good to go. So atypical locations findings, we describe those. Refer. Aspiration failure, you pull the jelly out once. That's pretty much what I tell patients. I'm only going to do it once. That's what I tell them. Whatever you choose to do is your clinical practice. But I will tell you, what's the recurrence rate? Very high, 85-90%. So it is proven it's coming back. So would you continue sucking the jelly out? No, that's a waste of everybody's time, right? Septic joint, well, duh, you're going to refer that, right? If it's an infected mucoid cyst that you were digging around in, you need to refer it at that point. We'll shame you, don't worry. And that's pretty much that. Okay? I want to stop there because osteomyelitis is something we'll hit. And then we're going to go right into spine next week. Okay, guys? Right? Hopefully the pace isn't going too fast, but I think we've established a nice base of knowledge and terminology, right? And you guys understand how I'm going to start talking to you guys? I'm going to start using words like radial, ulnar, right? Because next week when we start talking about nerves, that stuff's going to become super important.